This is John Weigelt, your coordinating editor for CSAP 17 Audio Companion. I am sitting here this morning with Dr. Charles Friel, one of our CSAP 17 authors. Charles, I'd like you to share with our audience where you are located, your primary focus of your clinical practice, and maybe a little bit about how you spend your usual day or week, if you ever have one of those.
Well, first of all, John, thank you for having me. It's certainly an honor to be part of the CSAP program, and it's been really fun working with you all these years. I am at the University of Virginia, and I am a colorectal surgeon, so my usual week is spending taking care of people with colorectal problems. I operate 2 to 3 times a week and see clinic patients once a week, and I'm also the general surgery program director.
Obviously, you've got a busy colorectal practice, but I think it's imperative that people like you assume the responsibility for training, and being a general surgery program director is a lot harder than when I was a general surgery program director, so I really do congratulate you on being able to do both of those things. And today, we're going to share some of your thoughts regarding topics from the alimentary and abdomen categories of CSAP 17. Now, many of the topics come from CSAP 17 questions, but there are some others that I'm going to ask you about based upon questions that were written but not selected for the final draft of CSAP 17. Yet they have persisted in my mind because of the great discussion that occurred among the committee members when the question was vetted in front of everybody. So that's my plan, and let's get started. The first thing I'd like you to clarify for the audience is there a difference between surveillance for colon cancer and screening for colon cancer?
For sure. I mean, screening really implies an asymptomatic patient, and we're looking for polyps or early cancers so that we can intervene earlier and have improved outcomes. Surveillance is really what we do when a patient has either had a previous history of colon cancer or a previous polyp noted, and then we have to kind of alter our plan because they're at risk to develop further polyps or cancers in the future. And so that process is really a different concept. Again, screening is really for the asymptomatic patient, and surveillance versus somebody who's already had a previous history of either colon cancer or a polyp.
Okay, well, let's start with screening, and let's start with, obviously, the general population. When should screening start, and which test are you suggesting we should use?
Yeah, so that's actually in evolution right now. I mean, for years and years and years, we would say that you should screen the patient who's considered to be the average risk for colon cancer. The most significant risk factor, of course, is age. And for years, as I said, that was age 50. But really, over the last 10 to 20 years, what we've noted is that there's really been an increased rate of colon cancer diagnosed in younger people. And just a few years ago, the American Cancer Society actually changed the initial screening age to 45. Now, we do have the U.S. Multi-Task Force, which still says 50, so we have a slight disagreement in the guidelines, but we're tending to lean towards an earlier age for screening. So that's the most important thing. Well, there will be some patients that we consider to be higher risk, and those patients may get screening earlier, and it's important to talk to your doctor. But certainly if you have a family history, especially a direct family of father, brother, sister, mother, then you should get colon cancer screening earlier. We generally say 10 years younger than the youngest relative. Another high-risk factor would be inflammatory bowel disease, and those patients should be screened according to their GI recommendations and in close consultation with their doctors.
So, Charles, when you say 10 years younger than the family member, that means the family member 10 years younger from when they've had their polyps or their colon cancer diagnosed. Is that fair?
That's fair. So if your father had colon cancer at age 42, then you would actually advise that that man's children should probably be scoped somewhere in their early 30s.
So the colorectal surgeon is going through the same dilemma that the breast surgeon is going through with you have two guidelines out there with two different ages to start screening.
I think that is fair to say. In general, I think 50 still seems to be the age that most people go by. Insurance companies probably haven't totally bought into the 45 age group yet. But what we definitely are seeing, though, is that people are getting colon cancer at a younger age, and that's disturbing. And what really it prompts us to say is that anybody who has any kind of symptom really should probably get an evaluation, and we shouldn't just dismiss it as hemorrhoids.
And you haven't answered my second question about what test you are promoting.
Yeah, so that's a good one. I think the best test is the one that will get done. And I think that is still a problem. There's still a lot of data that says people that should be screened have not been screened. There are certainly a lot of choices. My personal preference is lean towards colonoscopy. Why is that? Well, for a couple reasons. One is it's the most sensitive, and it's going to be the most specific. We certainly can see polyps and tumors very easily. The probably best rationale, though, is that we can identify polyps, and if we can identify those polyps, we can remove the polyps, and now we've kind of crossed from screening just for colon cancer to actually preventing colon cancer. A negative colonoscopy, too, in an average risk patient, you only have to do once every 10 years. So I must admit that's my personal bias. Now, having said that, there are lots of other options out there. There's still fecal occult blood testing, which is probably the test that's been most thoroughly studied. There's variations on that, the FIT test, which is also quite good. And now there's even the multi-targeted test, the Cologuard, if you will. And, of course, there's still flexible sigmoidoscopy. So there are a lot of different options that are available to the primary care provider, and the best test, again, is the one that actually gets completed.
Let me ask you, the idea that the multi-target stool test or for the DNA combined with the FIT is very sensitive but has supposedly a lower specificity. Are you finding that when you're dealing with patients who have been screened with the more advanced or the more complex test, if you will?
Truthfully, I don't see a whole lot of the Cologuard still being done. We see it from time to time. I suspect it's catching on. Now, my primary practice doesn't really involve kind of evaluating people who have a positive test. But nevertheless, as you said, the data suggests that perhaps there's some false positives. I think we could probably live with that. You know, the biggest issue, I think, for that test ultimately is going to be still cost. It's still relatively expensive, especially compared to fecal occult blood testing and FIT alone, which is really very inexpensive. So I haven't really delved into that too much, but again, the best test is the one that gets done.
Let's go back to that screening colonoscopy, and you remove a polyp. Does it matter what the pathology shows regarding that future follow-up? You said without polyps, it's 10 years. When you find a polyp, does the pathology dictate how quickly you have to follow that patient up?
Yeah, there's a rather kind of extensive guideline and a big table that I have to admit I have to look up myself because it gets kind of daunting to memorize the entire thing. But the bottom line is that if you have a high-risk polyp, you should be surveyed earlier. And what makes things that are high risk? A couple of different factors. Certainly larger polyps. So anything over a centimeter would be considered a high-risk lesion, and that would warrant an earlier follow-up, and that would probably be in the 5-year range. If you have a polyp with an aggressive feature, the villus adenomas are considered to be a bit more aggressive than tubular adenomas, for example. That would probably warrant a little bit earlier follow-up as well. And then the number of polyps, certainly if you find numerous polyps, then you certainly want to shorten that interval as well. And that interval can really range from anywhere to 3 years. If you find 12 or 15 polyps, you certainly want to be seeing that patient earlier, to 5 years in that range, to up to kind of 10 years if you have a normal colonoscopy.
When you've got a high-risk patient, I'm assuming you would go right to colonoscopy. There would be no reason to do any of the screening tests. Fair?
Yeah, I think that's totally fair. I mean, I think if you have somebody, for example, we talked about with a significant family history, certainly if they've been genetically tested and are known to have either Lynch or FAP, then you definitely want to be going to a colonoscopy. The other tests are really designed for the general population, and our high-risk patients really deserve colonoscopy.
Now, let me ask you to predict the future. I'm sure you're pretty good at that, just like I am, but we're going to talk later this morning about genetics as it relates to colon cancer. But my question is, when we remove a polyp, do you think we will ever be testing the polyps for genetic changes?
I think undoubtedly. I mean, I suspect at some point we'll just be checking their bloodstream for genetic changes. If I'm really going to predict the future, which I can't, as you know, but we already, to some extent, do look at high-risk polyps. We look for the different mismatched Berkshire genes, and that may influence us. I mean, that's tending towards the cancer diagnosis. But the whole premise of the multi-targeted Cologuard test is to kind of find these genes in the stool, for example. So I think undoubtedly we're going to be looking at genetic kind of footprints and trying to determine your personal risk factor and then really screen and survey based on those type of details. I think for sure that's going to happen.
But currently, when you take a polyp out at the University of Virginia, you don't get a report back from the pathologists about any genetic findings that they have in that polyp.
That is fair. Not for the polyps.
Let's talk about colonoscopy a little more. And I think everybody agrees that diagnostic colonoscopy is a safe procedure overall. But I have a question. Have the quality indicators for colonoscopy helped make it safer, or has the safety always been there and really the indicators are focused at making it more accurate?
I think the latter is probably true. Over time, we've all gotten better, and we've got better technology, we've got better viewing, better optics. But in general, colonoscopy has been a pretty safe procedure for a long, long time. I do think the quality indicators really focused on making sure we're doing a good exam. It's very easy to kind of get into that trap of trying to get 20 colonoscopies done in a day, and you're kind of going in and out too quick. Perhaps your bowel preparations aren't quite as good. So I think the indicators really are focused on making sure that the quality of the exam is excellent and I think reproducible. And I think it's important for surgeons to understand that because we're being judged by the criteria for GI doctors as well. Many surgeons have a very active endoscopic practice, and they just have to be aware that they really are going to be judged by the same criteria as their GI colleagues.
Now, you mentioned your prep, and everybody I talk to about colonoscopy always abhors the prep before the colonoscopy, I think, more than the procedure itself. There's one question about a split prep with half in the evening, half in the morning. Is that something that's becoming more common?
Yeah, 100%. And you're right about the prep. I mean, the patients still say, I don't know why we could put a man on the moon and we can't make the prep more tolerable. But nevertheless, that seems to be the biggest problem. And so the quality of the preparation is really critical, and I'll even tell my patients that. Really do your best because, to get a poor exam is really not worth your time. So what we do now with our mechanical preps is exactly what you said, which is called a split dose prep. You usually take, half or so the night before, and then you have a few hours before the exam, you then take the other half. And the idea is to really kind of, fundamentally wash out your colon with the big kind of washout at the beginning, but then right before the exam, really kind of get the residual stuff out. The split dose will be somewhat dependent on when your exam is. So if you have an exam later in the day, you might have to take the second half in the morning. If you have a very early exam, then sometimes we don't do the split dose because it's a little unfair to ask our patients to get up at 3 a.m. to do it. But nevertheless, I think you do get a better prep if you divide it in half.
We've talked about how safe colonoscopy is. What is the complication rate that we should expect from a diagnostic colonoscopy?
For a diagnostic colonoscopy, really you should be well less than 1 in 1,000 to have any kind of mechanical problem, including perforation, which is really all you would get because if it's diagnostic, you're not doing a polypectomy. You can have other problems related to the sedation, but I would say well less than 1 in 1,000.
And if a polypectomy is done, how much does that increase the complication rate?
It's still very low, but it does increase the rate considerably, honestly. But again, the rate is very low, and that's related to the cautery effect from the device that you're using to remove the polyp.
What if you recognize a small perforation at the time of the scope? What do you do in that case? And you've got a well-prepped colon, but lo and behold, there's a small perforation.
Yeah, that's interesting. Unfortunately, I just had my first one just about 3 or 4 weeks ago, and that has really changed as well. I mean, I think 10, 15 years ago, if you had a hole in the colon, you pretty had no much choice but to go to the operating room. Now we have the ability to clip the colon itself endoscopically. In my case, I just had about a 3-millimeter hole. It was clearly a hole, and I could see it clear as a bell, but we were able to just put clips on it. The first time I saw that was about 5 or 6 years ago. I was skeptical, I must admit at first, and then I watched my GI colleague place the clips on, and I looked at her and I said, I don't think I could have done that better in the operating room, and the patient did fine. So we do have endoscopic options, which are really quite good. For larger holes, that is the problem. And so for these really large defects, which really are usually due to the elbow of the scope, can create very large defects on the order of 2, 3, 4, 5 centimeters. And unfortunately, those are still going to require an operation.
So your experience with clips is helpful for our audience because we've had a couple of your colleagues talk about clips for esophageal perforations, colon perforations, and it doesn't seem the experience is very great. Does your GI colleagues identify how big they are willing to push the clip closure?
Yeah, that's a good question. I don't know. We're headed towards an era where we're going to deliberately do this, right, where they're going to actually endoscopically remove things and then clip them closed. I still think at this day and age, I think we're talking about defects that are well less than a centimeter. I think also the location matters. In the particular case I was discussing, it was in the rectal area where we got a little bit room for forgiveness because it's in the retroperitoneum. So I think the location also is critical to how aggressive you're going to be with clips. But I think clips really are a good alternative, and I'm shocked at what we can now do with the endoscope.
When you have that small perforation you close with a clip, do you hospitalize the patient? Do they get antibiotics? How do you follow them?
Yeah, so I think that's probably wise. I think we're still a little bit fuzzy on how good that can be. So I do put them on antibiotics, and I certainly hospitalize them, and I just follow them by the clinical exam.
Do you keep them NPO, or you feed them right away?
I keep them NPO for at least 24 hours just to see how we're going.
Let's talk about another complication, which is the post-polypectomy syndrome, which I think you've already insinuated something about. It's always ripe for a test question. So what is it, and how do you manage it usually?
Yeah, so the way we perforate the colon when we're doing endoscope, we've already alluded to one type of injury, which is really either mechanical trauma or barotrauma. The most common thing is, again, the elbow of the scope, which just causes mechanical problems. And those tend to be large holes. The second way we injure the colon is actually with the effects of the electrocautery that we use to remove polyps. Honestly, once we remove them, those defects can be quite small or even microscopic. You could get a full thickness burn through the colon, which doesn't actually create necessarily a frank hole. Those patients, however, might go home and then return to your ER with some localized pain. They may even have some fever. Their white count may be up. And when you get a CAT scan, you maybe see inflammation around the area of the polypectomy. And that can be scary as a surgeon. In some instances, there can even be some localized free air, and that does indicate you had a full thickness injury. But those things are often small. It's a little bit analogous to, localized diverticulitis. And as long as they don't have systemic sepsis, we can manage those patients non-operatively with antibiotics and observation.
How long do you usually keep them in the hospital?
Well, it depends a little bit how they're doing, but usually it's usually about 24 to 48 hours. Fortunately, again, this is relatively uncommon, so we don't see it that often.
That's why it's a test question, right?
Absolutely, because what we don't want to do is overreact, and I think that's the biggest issue. Now, if the patient develops signs of peritonitis or clearly is getting more septic, then certainly operative intervention is warranted at that point.
There was lots of discussion among the committees regarding sessile polyps, including yourself. So how do we diagnose them? Is there tricks when you're doing colonoscopy? Do you need to use special techniques to identify sessile polyps?
Well, the first important thing is making sure your equipment is up to date, it's modern, it's high definition, and you're paying attention, because they are visible. I still pretty much use white light. Our GI colleagues have different light techniques to identify the polyps, so they make them stand out a little bit more. There's narrow band imaging, for example, and my GI colleagues use that quite a bit. As I said before, that once they do that, if you look at it, you can see it under white light. So really, close attention is probably the most important thing.
So you've got a half a centimeter sessile polyp that you think needs to come out. How do you resect it?
Yeah, so most of the time we're going to be doing that with a snare technique. A lot of times the safest thing to do, though, is to try to lift the polyp. And so you can inject. I usually use saline, but there's different products now that actually are commercially available to help inject right underneath the polyp. And what you do is you lift the mucosa off the submucosa, and you create a little bit of distance so that first of all, you can grab the polyp a little bit easier, but in theory, too, the cautery effect won't go through the bowel wall, and allows for a bit of a safer resection. We've kind of lumped all these things together now to call them, endoscopic mucosal resections, or EMR. I think some of these techniques have been around for a long time, so the new terminology sometimes gets a little confusing, but that is what people are kind of calling that now.
I know you don't want to do this, but what if you have to take it out in pieces instead of as one piece?
Yeah, so we do piecemeal resections all the time. In an ideal world, you could take it out in one piece, but as they get larger, that really becomes impossible in some cases. However, it's still much better than having a resection. And so a piecemeal resection is a completely reasonable approach to these larger polyps. It's really important, I think, too, to then photograph them when you're done, because I think once especially if you've had a lot of experience, you can look at photographs that people have showed you of work they've done, and you can say, I'm pretty confident that person got that polyp out. And they can do an incredibly good job now.
When you do one of these lift procedures, are you following the patient any different than when you have a pedunculated polyp, nice stalk, take it out? Do you do anything different?
Yeah, for sure. I think what you're alluding to is the recurrence rates for these things. And there's no doubt that these piecemeal resections have a much higher recurrence rate. So depending on the size and how much work you did, we'll even follow those patients up in 6 months, because we want to make sure that they really were totally endoscopically removed. I think one, critical point, especially to surgeons, is to realize that we do have really good endoscopic techniques to manage these polyps. There is pretty good data that up to 30% of patients who get referred for a resection, if a person with advanced endoscopic skills rescopes them, they can remove those polyps and avoid a big operation. And I think we owe it to our patients to really give, and skilled endoscopists a chance at taking out what is really a benign disease process.
And when you say 6-month follow-up, that means another colonoscopy at 6 months, or you do intervals in shorter periods even?
It can be 3 to 6 months. That will be up to the discretion of the user. But you certainly need to do you have to do a full colonoscopy in the sense of getting to the cecum? Maybe not, but you have to be able to get to the lesion itself. The other really critical part of that is if you have a piecemeal resection, you should mark it by placing a tattoo next to the lesion itself. And that's really for two reasons. One is if you're surveying it later and you've done a good job, it's really hard to know where it was if you haven't marked it. So if you've clearly marked it, you can say, listen, I saw the tattoo, there's no polyp, I feel good that we've done a good resection, and then you're done. The second reason is if, unfortunately, the path comes back with cancer in it, then you are going to have to move to a resection, and the surgeon has to know exactly where that polyp is located. So tattooing is really critical as well.
You have talked about tattooing before in our discussion of many questions, but I don't think I've ever asked you, what product do you use to tattoo?
We use a product called Spot. It's just a carbon-based product. It's commercially available. If you're in the endoscopy suite, you just ask your tech to get you the tattoo. It's just a small needle that you put through one of the channels. It's pretty easy. It's just like raising a wheel if you're doing local anesthetic for a local skin excision.
Let me bring genetics into this, and let me ask you a question regarding sessile polyps versus pedunculated polyps. Is there a different pathophysiology that we now recognize?
Well, you're probably relating to these sessile serrated polyps.
Yep.
We certainly have sessile polyps that are villus adenoma, for example, that really kind of follow the same genetics that we've always thought about. But what we've really noted in the last 10 years or so is that there's a second type of polyp, these sessile serrated polyps. I think sometimes they've been called the flat polyps, and they really do have a different kind of pathophysiology. I think the regular polyps, if you will, were really associated with the APC gene. These sessile serrated polyps are really associated with a different process, which we call hypermethylation. The really, I think, scary part about these polyps probably mature at a faster rate, and they're really accounting for these interval colon cancers. People who have had colonoscopies at the right intervals, and despite the fact they get a colon cancer. And these sessile serrated polyps that have grown into colon cancers are disproportionately represented in that patient population. And they can be hard to detect. They can be very flat, and they can be very subtle.
And when you resect a sessile polyp that you suspect might be malignant, what's the acceptable margin on that resection?
Yeah, so I think we try to avoid, if you will, if I look at a polyp and I'm really confident it's malignant, generally I will just biopsy that. But I think, again, what you're alluding to is that these larger polyps, it's really hard to tell. And certainly it's a great benefit to our patients if we can take something out and avoid an operation. Unfortunately, sometimes we take a polyp out, and despite our best intentions, we find an invasive cancer in the polyp itself. It depends a little bit, and this is why documentation and even photographs, depending on whether it's sessile or pedunculated, the risk of developing metastases is dramatically different. So let's start with the pedunculated polyp. The pedunculated polyp can be, even with cancer in it, a polypectomy can be curative. We have traditionally talked about Haggett levels, if you will, and really what it says is that if you have a little bit of invasion at the very tip of the polyp, or even towards the neck of the polyp, the probability of that invasive cancer going to the lymph nodes is extraordinarily low. So if you think about what we're trying to do as a surgeon, when we resect a tumor, one, we resect the tumor, and two, we take out the lymph nodes. So if we've been successful taking out the polyp with the endoscope completely, then we've checked that box. We've resected the tumor. And if we have no chance of having cancer in the lymph nodes, then adding an operation really doesn't help them. So we try to separate these patients into low risk and high risk. And the Haggett level would be one way.
So the Haggett classification is something that general surgeon needs to know something about.
They should be aware of this. Some of that terminology is kind of going away, but the concepts remain the same. The difficulty, the Haggett level 4 polyp, if you will, is really right at the base. And so if you are really at the base, then the risk of nodal metastases does increase, and it can hover in the 10-15% range depending on other factors. And that's when we start talking about the risk of not doing surgery is too high. When you get to sessile polyps, this is where it gets a little bit more complicated. Historically, we've always considered sessile polyps to be quote-unquote Haggett level 4s, and therefore all sessile polyps mandated resection. I think what we've learned now is that that's probably not true, that really it depends on the depth of invasion of that particular polyp. There's been a lot of work, especially in Japan, looking at a sessile polyp and dividing the level of invasion. And it gets a little technical, but if you look at the invasion into the submucosa, you can divide it into the upper third, the middle third, and the lower third. And it turns out that the risk of nodal metastases, if you're in the upper or middle third, is actually very low and very similar to just at the head of a polyp. Once you start getting into the last third, the lower third, you're almost into the surrounding muscle, and then the rate of metastases does increase to 10 or 15%. So how does that translate into what we do pathologically? I think what we've now saying is that as long as you get a resection on the polyp and your margin is at least 2 millimeters, then probably you've got a superficial polyp and that you're probably going to be okay. And so that's a key pathological parameter, and you really got to work with your pathologist to try to get that information.
And that 2 millimeter margin includes a level 4 sessile polyp?
Yes. So if you have a 1 centimeter polyp and you inject it with saline and lift it, and you take it out in one piece, and you have some invasive cancer, and it does not have some of the poor pathological features which we have not yet discussed, and you have greater than a 2 millimeter margin, then you're probably done. You can just survey that patient.
And if it does have some characteristics that are poor, such as lymphovascular invasion or poor cellular differentiation, then more is needed?
Yeah, so then we get into the next part of this. And what we're trying to do is predict the probability that you have lymph node metastases. We've really just talked about margins so far, but there are other predictors. So if the tumor itself is poorly differentiated, has lymphovascular invasion, has evidence of tumor budding, all of those are aggressive pathological features. And then really all the other margin stuff, all bets are off, so to speak. And the risk of nodal metastases increases probably in the 20 to 30% range. And so for those patients with those high-risk features, we would recommend that they have a standard oncologic operation.
Well, let me ask you a question about the identification of what you're really trying to predict, which is the lymph node metastases. Our foregut colleagues are using more endoscopic ultrasound to identify various things before foregut surgery. Is anybody trying to use the endoscopic ultrasound through the colonoscope so that you could maybe even identify lymphatic spread or lymph node enlargement?
Yeah, so again, I 100% agree that our goal is to try to predict lymph node metastases. There has been a lot of endoscopic ultrasound work in the rectum. It was the staging modality of choice for years and years. And you can, to some extent, identify enlarged lymph nodes, at least in the mesorectum. And if you've got a good skilled endoscopist, they can even sample those with FNA and whatnot. Unfortunately, it relies on size, which is not always the best predictor. Certainly enlarged lymph nodes are more worrisome than smaller ones. But we know that some small lymph nodes can have cancer in them. So it's not the perfect test. The second thing is that it's, at least in the colon, it's fairly limited to the rectum. So Most of these polyps that we're dealing with, what I would call a malignant polyp, occur in the colon, and we just don't have great imaging to sort that out quite yet.
We're going to come back to colon and rectal cancer, but let's step away from the discussion of malignancy and talk about a favorite topic for CSAP-17 and other CSAPs, which was diverticular disease. So there are a whole bunch of discussions I want to pick your brain about, and let's talk about diverticulitis first. So is the cause still a piece of feces that gets stuck in a diverticulum?
I think the reality is we don't totally know. I think it certainly is a feasible explanation. Certainly if you do a lot of colonoscopy, you see a lot of diverticulums with little pieces of stool in them. But I see a heck of a lot of pieces of stool and pieces of diverticulum, and they don't all get diverticulitis. So I think we don't totally know. It turns out that diverticulitis is, I don't want to say relatively uncommon, but if you compare it to the incidence of diverticulosis, most people don't get diverticulitis. But because diverticulosis is essentially universal by the time you get in your 60s, 70s, and 80s, we see a lot of diverticulitis as general surgeons.
And then the question that didn't make it into CSAP-17, although the discussion was emotionally charged, was whether or not fiber helps prevent attacks of diverticulitis, especially in a patient who's had recurrent attacks, and you're trying to help them potentially prevent future attacks.
Yeah, I don't know if we have any, actual evidence that a high-fiber diet prevents future attacks. I think the assumption is that a high-fiber diet is probably healthy for us in general. So what I tell my patients is that it's good for your cholesterol, it's good for other things as well. So certainly there's a reason to pursue it. Whether it's actually going to prevent your future attack, I'm just not sure we have that evidence. I think what we would like to see, and I think we're probably headed in the other direction, is that a lifetime of fiber, starting when you're born, so to speak, will prevent, hopefully, diverticulosis, which ultimately has the greatest impact. It's just that the American diet has kind of veered away from that, and that's why diverticulosis is almost ubiquitous now as we get older.
Okay, well, another discussion topic that didn't make it into CSAP-17 was the idea that antibiotics are not needed to treat mild cases of diverticulitis, with some literature now advocating no antibiotics. You have any comments?
That always is a hot topic and a bit of a heated debate. There's actually, quite good evidence, mostly from our Scandinavian colleagues, that for mild cases of diverticulitis, and these are usually outpatient folks that don't have high white counts and don't have fevers and aren't systemically ill, there was at least one large trial which really demonstrated no significant impact on the outcome whether they got antibiotics or not. So I was at a recent national meeting, and our European colleagues are now saying they don't give antibiotics. In the U.S., I think that is a hard sell. Even some of my colleagues on the podium said, if they don't give them the antibiotics, somebody else will. Our patients want antibiotics, but there is pretty good evidence that for these mild cases, antibiotics may not be impacting the overall outcome.
Let's up the stakes a little bit. So in the patient who you make a diagnosis of diverticulitis, they've got systemic signs of inflammation. The CT is consistent with inflammation around the sigmoid colon. They get treated with bowel rest and antibiotics. Is it always as an inpatient?
It really depends on the clinical situation. I think anybody who has any kind of significant systemic illness, you probably should follow in the hospital. If a patient has, significant pain, the white count's 15,000, they don't have a high fever, then maybe you can manage that patient as an outpatient. But once you're worried, then I think probably monitoring makes some sense.
And we've all had the patient where that picture is there, and on on that CT scan, the radiologist calls you up and says there's a speck of air above the liver or right around the sigmoid inflammation. Does that change your approach?
So again, it really is going to depend on how the patient is doing. You are not mandated to operate for those indications. Frequently, we'll have patients that have those type of findings, but when you go and see them, they're not that ill. Their heart rate's not high, they're not hypotensive. They might have some localized tenderness, but they don't have evidence of diffuse peritonitis. And I think under those circumstances, the assumption is that there was a small perforation, that it may be already sealed, and that those folks may benefit from just a conservative approach with antibiotics and bowel rest. They ultimately may need a resection, but if we can change this kind of emergency situation to an elective one, we always seem to have better outcomes.
Well, that 50-year-old male that has been treated now with the bowel rest and antibiotics is well. What comes next?
So I think it also depends on how the patient themselves are doing, and it really depends to some extent on how many attacks they've had. We used to say after 2 attacks you get an operation. That clearly is no longer the case. What we really need to do is kind of assess their individual risk. So the decision-making is quote-unquote individualized. What I tell folks is that the way I make that decision, it depends on several factors. One is the severity of their attack. Was it complicated or uncomplicated? And so how do I define that? Well, if you had a large abscess, I would consider that to be more complicated. If you just had inflammation, that would be considered uncomplicated. Certainly, if you have any other problem like a fistula, that would fall into the complicated category. And most patients with that type of disease are going to require some sort of operation. For our patients who have less severe disease, then you may make that decision based on how often it's been happening. If you've had an attack this year and you had one 2 years ago, then I would probably say I would just wait if I were you. If you have 3 in the last 3 months, then that's probably your body telling you something needs to be done. In general, though, I think we historically probably operated way too much on diverticulitis, and I probably talk more people out of operations than talk them into it at this point.
The other hot topic among CSAP 17 committees was the treatment of perforated diverticulitis, especially laparoscopic lavage and drainage. Is this appropriate treatment in the colorectal community?
Yeah, so you're probably going to reflect a little bit of my bias here. That became kind of a hot topic, I don't know, probably 5, 6, 7 years ago. I think to most of us it sounded a little out there. There is some evidence that suggests that some people do well. There was a whole host of prospective randomized trials in Europe. Most of them, I think, came to the conclusion that although some people have better outcomes, there's still a significant complication rate and reintervention rate that makes most people, I think, uncomfortable. So at least in the colorectal world, the laparoscopic lavage has kind of taken a back seat and faded a bit. Where is the Achilles heel? I think the underlying assumption is that something perforated and something sealed. And I think what we're finding is up to 20% of people, it probably wasn't sealed. So if we're ever going to put this in our armamentarium and really kind of assess this in the future, we have to have some ability to really detect whether people have a true hole in the colon. So if you're going to pursue something like this, I at least tell people you probably got to put an endoscope in. You have to blow up the sigmoid colon. You got to make sure there's no air bubbles. And if you see any, then you just have to resect it.
Do you think that the Hinchey classification, when they tried to push this technique to feculent peritonitis or Hinchey 4, that was a wrong decision?
For the lavage, it was actually, the selection criteria was purulent peritonitis. So you put a scope in, and if you saw just pus, then you could be randomized into a lavage. If you had true feculent peritonitis, the assumption was that you had a macroscopic hole, and those patients were not randomized to the lavage. Those had got some sort of operation. Again, I'm not a big fan. I've never done it. I don't think it's probably the procedure of choice. But if you're going to do it, then it's only going to be indicated in purulent peritonitis.
All right, well, let me ask you one more question about diverticulitis, and that's about pneumaturia and a colovesical fistula. Is the diagnosis always as easy as the doctor books say it is?
It's pretty straightforward, honestly. Patients know when they have pneumaturia. Thank God I've never had it, but I can tell you that they come in saying they're peeing air, and almost always when they tell me that, there's always a fistula. I then confirm it, and I think the best test is just a CT scan, and then I think the most sensitive thing is just to see air in the bladder. There's no reason to have air in the bladder if you haven't had any recent instrumentation. So I think if the patient says they have pneumaturia and they've got air in their bladder, then to me that's the diagnosis.
We had a question about an elderly patient with pneumaturia, no previous history of diverticulitis. And the question was, do you need to do colonoscopy to exclude a cancer in that kind of patient? Is it safe to do colonoscopy, and is that what you would suggest?
Yeah, I would 100%. I think, there is some, I think this also begs the question, for any routine diverticulitis, do you need a colonoscopy? I have to admit, I still tend towards the colonoscopies because I want to make sure we're not missing an undiagnosed cancer. But even in that literature, if you have very simple, straightforward diverticulitis, finding a colon cancer is fairly unusual. But once you're kind of getting into complicated disease, and I would count colovesical fistula as being complicated, that the rate of finding a cancer can run into the 10% range. So even if you're really confident, and being 90% right is pretty good, you don't want to stumble into finding a cancer because your operation would be different. So I for sure would scope all those folks.
That's the end of this session for this category of the CSAP 17 audio companion. This category will continue in the next session.